morning. Thank you for the opportunity today to talk about PRRT. I'm Mike Herman. I'm a radiation oncologist here in Austin, Texas, and we're happy to offer this program here for the people in Central Texas. So what is PRRT? So it's a peptide receptor radionuclide therapy. It's a really unique molecule that attaches to a cell and is able to deliver the radiation to the cell at that cellular level. So it's a radioactive particle that kills the tumor cell from within. It's administered by an IV infusion. It can take several hours, and each PRRT has its own kind of unique scheduling protocol. One of the things we wanted to highlight today is just that we want to make sure that we're communicating with our treatment team. So just like you're doing today, we want to educate ourselves, and probably more importantly, educate your family members, because they're the ones who are asking those questions after your visit with the doctor. So you want to make sure that you're understanding what you're getting into, understanding the disease, and understanding the process. You want to make sure that you communicate, and communicate often. A lot of times patients are kind of embarrassed or don't want to share certain symptoms that they're having, but those symptoms can make a big difference when we decide our treatment plan. So you want to make sure that you're always in open communication with your therapy team. And then one of the things that has been highlighted several times in other talks is that we want to make sure that your treatment aligns with your values. So what are you trying to get out of the situation? What do you want long term? Those are things that we need to make sure we're constantly communicating with the patient and their family. So some key things to remember. We may not want to admit this, but the physician plays a pretty small role in PRRT. So most of the day that you're sitting there, you're getting to know the nursing team, the nuke med tech, the physicists, and so you want to make sure that you can jive with all of them. So one of the things to do is probably get to know who you're going to be hanging out with for 4 to 5 hours, and make sure that you enjoy them, and that's part of your treatment team. So that's an important part of this. I want to make sure that we're level setting time expectations. So when I meet with patients, I spend a lot of time explaining a couple things. One is a lot of these drugs are manufactured by 1 or 2 places, and so your timing of treatment is out of my control, meaning that we're going to try to talk to that company and figure out when you can get scheduled, but it may not be next Tuesday at noon. It may be a month later or 2 months, depending on what the manufacturer is saying. So you want to make sure that you're in kind of open communication with your schedule and also have some grace when it comes to the scheduling time. These drugs can be unbelievably expensive, and so we want to make sure that we give the financial team time to maximize your benefit. And so that's another kind of group of your treatment team you want to get to know to make sure we're trying to find everything possible to limit your out-of-pocket costs. There's a rigid schedule protocol to a lot of these drugs, and so when we set your timing or dates, we want to make sure you prioritize that when you're making your own individual schedule. The day of the treatment. So the best thing that you can do is to make sure that you get some good night's sleep for several days before your treatment. You want to make sure you're having a well-balanced, whole food diet, and then just make sure you are well hydrated. That will help with your IV stick, your IV infusion, but also help you to urinate that pharmaceutical as quickly as possible. You're also going to have a pretty boring time while you're getting the treatment. We've had some really good supplemental treatments to help with the side effects, and so you want to make sure that you have a good book, magazine, your iPad, or some movies to occupy the time. The other thing you want to ask is, going into that treatment protocol, is you want to know what are some potential restrictions after you get the treatment. So those can include, sleeping in your own bed for a couple days to minimize the time that you're with a loved one or a loved pet. You want to know how long you can be staying away from pregnant women or children, how long it's going to take before you can get on a plane and go somewhere for travel, how long you want to be on a long car ride with other people, and then also just what are some precautions that you want to take. And so these are just good questions to ask in your initial visit. These are things that we should be going over with you and giving you a lot of printed protocols so that you know what you're getting into before your treatment. So I just want to pass that along to our next speaker here.
I am going to talk about a lot of different things. What I tried to do with this talk is put myself in your shoes and say, okay, I'm going to go on the internet and I'm going to see what happens when I Google PRRT or alpha or beta or whatever. And I did that, and I spent about 13 hours or so just deep diving in there to see what was going on. So I'm going to talk about a lot of things that aren't available right now. And I'm also going to be talking about some stuff that I am personally involved with or have been involved with on trials. I don't have any financial interest in those, but I just know a little bit more about those because I'm on them. So if I seem like I'm talking about one more than the other, that's why. It's not because I'm getting paid, all right? All right, so let's say you come in, and the first thing that is probably going to be your exposure to nuclear medicine is some sort of an imaging scan so that we can take a look at your tumors, right? And there's multiple that are available. So I think it was mentioned before that OctreaScan was something that we had initially available. We used that for a long time. It's been around as long as I've been in the field. But it's really, honestly, no one should be getting an OctreaScan anymore. My field, as strongly as they can, you know, we put out these papers and we say, we strongly recommend this, that. This one is out here. You know, if at all possible, try to avoid the OctreaScan. It's just not as good. We can't see as much. It also takes a lot longer. It's like a 2-day procedure. So we've moved on. We really like PET. And there's multiple things that you could potentially get as far as the PET imaging for your neuroendocrine tumor. There's something called 68 gallium or gallium-68 DOTA-TOC. This was actually one of the first ones. It's really not very available, and that's because a company really didn't pick it up. They have now, so it might be coming around a little bit more. What is the difference between getting a DOTA-TOC scan and a DOTA-TATE, or the net spot that probably a lot of you have had? Nothing, really. I mean, it's a little bit different in terms of how the receptor part of the agent is looking for those somatostatin receptors on the tumor, but they haven't really shown any difference in any study that I've seen. You're probably going to end up with a net spot just because it's more available. What about copper? Copper-64 DOTA-TATE or DetectNet. You'll see DOTA-TATE, DOTA-TATE. So it's going after it the same way. It's just a little bit different in terms of the radioactive particle that's what lets us actually see what's going on. And then just briefly, an FDG PET-CT, that's looking at sugar, basically how tumor is using sugar rather than looking for a receptor. Sometimes we use this in NET because it can be a marker of a more aggressive type of tumor. Not necessarily, but that can be helpful sometimes. And then an I-131 MIBG, I forgot the I on there. That is pretty much more specific for pheochromocytomas or paragangliomas. So we don't use it nearly as much as the others, but in certain circumstances we do, and that's also a 2-day test. So I was asked specifically to say, well, what about gallium DOTA-TATE versus copper DOTA-TATE? It's the same binder, as I said. Pharmaceutical is a little bit different. We make the gallium in a different way. It's made with what's called a generator. And its half-life, or how long it takes for half of the radioactivity to disappear, is about 68 minutes. So we contrast that with copper, which is what's called, ooh, how did I do that? Just waved my hands magically. Copper is made in what's called a cyclotron, where you bombard particles, and it has a much longer half-life of almost 13 hours. So we've got about 1 hour, and then we've got about half a day, right? So just in case you're wondering, we've got a generator. You don't plug it in. It's actually like a chemical generator. And I've made it look, it's the white thing on the side here, and I've made it look like it's pretty big just because I'm not really good at sizing things. But it's probably about the size of that little component that's over on the side of the cyclotron. The generator will run you about $80,000, in case you're interested. You have to replace it every 6 months. And the cyclotron runs you about $1.7 million, and then there's a whole lot of stuff you got to do to keep it running. But it lasts theoretically forever once you have one. So why might I pick one over the other? Well, the half-life matters. If you do not have access to a place that has generators, because, you know, they're expensive, not everybody wants to buy one. $80,000 is not something to sneeze at. Copper may be a better thing because there's much more time to have it made in a cyclotron, transferred to whatever facility you're being imaged at, and used before the radiation is all gone and we can't see anything. So that's something that could make a difference. Production limits. So a generator, one generator we can get about 3 net spot doses off of, or gallium dotatate, I should say, because if you can actually have your own generator. So 3 a day, so like for us, we can get at MD Anderson from a particular company up to 9 doses in a day because they have 3 generators. 9 is a lot. We don't really need to maybe look for anything else, but that can be a limit for other places. Ordering. Interestingly, we have to order the copper agent 2 days in advance, which can actually strangely be a problem because sometimes we're asked to do same-day scans or next-day scans. It's okay, Dan, we get it. So in that case, we can't even get the copper in time for when somebody wants us to provide not just the scan, but a read on it. So, we might not be able to get copper. And then there's these imaging issues. If you look at some stuff, and I will say it's sponsored by the company, it says, copper has a better imaging profile. Well, it kind of depends, because you have to scan them a little bit differently, perhaps. Like you have to go a little longer with the copper, and copper can also actually kind of break apart from the linker a little bit easier. So it kind of depends on multiple factors. So what do I think? I think if you showed me these 2 pictures and asked me which one is copper and which one is dotatate, I would only know because I put the slide together. You'll notice that if you have a really sharp eye, one of them looks sharper. That's because we have this special fancy scanner, one of 3 in the country, that's super duper sensitive. We actually put our coppers on that one because we don't want to change our scanning parameters, and that's what we have to do to make it look better. So ultimately, whether you get a dotatate with copper or you get a dotatate with gallium, really, dealer's choice, as far as I'm concerned, as long as the imaging parameters are held to the best standard for that particular agent. So that's copper versus dotatate. I have no absolute preference. How about experimentally imaging these? Well, if we could get what's called a fluorine or an F18 imaging-based agent for this, that would be great, just because it's got the best imaging characteristics, I think. But these are experimental. We don't necessarily need them, but it would be kind of cool. And then there's something called somatostatin receptor antagonist. And this is kind of a debate in our field. So the other ones are the agonists, and then there's this idea of an antagonist, and it's just a different way of how the particular material is getting onto the receptor on the tumor cells. And there's some thought one might be better or the other one, and it's still an investigation, but you might hear something about that. And then there's some ideas of, well, can we do something kind of matched with PRRT to say, could we look at advance, do an imaging in advance and figure out, hey, based on this person's tumor, what could we actually target these cells with the radiation and maybe kind of change up how much of that PRRT we're giving. And we can't do that with the gallium agents because you cannot do this thing called dosimetry to sort of tailor your treatment with only an hour-long half-life. So there is some thought that you could do this dosimetry and more tailored treatment as a pairing. We don't have that available right now. There is this possibility of a copper agent with that 13-hour half-life, of maybe doing that with a copper 67 type PRRT, and I'm going to talk about that a little later. Okay, so where are we? So we talked about Lutathera already. That was approved in 2018. I was thrilled to be a part of that. Basically, the standard is you get 4 treatments, 8 weeks apart, so sort of a 6-month course. It was initially approved for patients with mid-gut, so like small bowel tumors, who had well-differentiated grade 1 and 2. Why did we love it? Well, we loved it because of this progression-free survival difference, about 28 months versus about 8 months with the injection arm. There have been some subsequent analyses where people kind of have looked at it. Well, what about pancreatic? You know, so that kind of supported the same data. When we give this now, we kind of don't differentiate between whether the fact that, oh, it just says that it was approved for mid-gut, well-differentiated. We give it actually pretty freely to a lot of different kinds of patients right now. What about retreatment? Well, when you ask Dr. Google, the best thing that I could find, and I knew about this study before, is actually Dr. Strosberg, who was the lead author on the NETTER-1 paper, went back with some people, and they looked at a bunch of different studies where people had done retreatment and found 13 papers where they felt like they could kind of compare these. And what they found was that it didn't seem to be any more toxic to patients, which is great, and that in general, about a year or so of progression-free survival. So everything we have says probably not going to last as long on average as the first time you get it, but certainly, a year long, that was about what it was for everolimus. So it's sort of like, okay, well, that's not something to just, say, oh, that's no good. That's something where we do consider retreating patients, and we do this at MD Anderson. We tend to want to have patients not have any growth of their tumor for at least a year after finishing up. And we tend to start off offering 2 cycles because the data that's out there is kind of most supportive of that. Is there some reason why people couldn't get 4? No, not really. And in fact, I found a trial that they're going to do in France where they're actually going to look at this and say, is 2 better than 4? Is there more side effects? Whatever. So right now we're doing 2, but there's nothing really inhibiting me from saying, if Dan asks, let's say, can we do 4? We could probably try if the patient is looking great and doing well. How about expanding some indications as well as retreatment? So we've just sort of gotten into meetings about the NETTER-2 trial. Basically, what we are doing with NETTER-2 is we're looking at it as a first-line therapy, so not far down the road, like right up front. And specifically, this trial was looking at patients with grade 2 and grade 3 well-differentiated tumors, so a little bit more, I guess you would say, aggressive in some ways. And also, there is a part of it that it is looking at retreatment. So right now, we're actually getting into the manuscript preparation phase. I think this is going to be expanding our horizons a little bit with the treatment of NET. It's going to take a while to get any retreatment data, honestly, because they can still people can still join on like up to 4 years after the randomization. So we'll see if this adds any information, but as I said, we're kind of already doing it, so. And then how about other types of tumors? Lung, there's some data about that out there. Paraganglioma, pheochromocytoma, those types of things. There's some people doing some trials. There's even some trials that are going on at my institution looking at like prostate and brain tumors, so wow, okay. We're actually already pretty much giving it for people who have lung and paragangliomas. There might be, initially there was some issues with insurance wanting to cover these, but we luckily haven't had issues with that recently. I think the companies are kind of understanding that this could be helpful for those as well, but the data isn't necessarily as robust as it is for the other types. Okay, this is I'm getting into it finally, what everybody kind of wants to talk about, the experimental agents. First off, just a little refresher, I don't know how well this projects, but there's gamma energy. That's what we use to take all the pictures. It travels far, but it doesn't have as much energy behind it. So we can pick it up, but it doesn't really do anything to the cells inside the body. Then we've got the beta, which is what Lutathera is. Beta's electron energy. It doesn't travel very far, and it has a lot more energy than the gamma, so it will actually cause damage to cells. And we talk sometimes about cross-firing, because the thought is that a beta can't necessarily do what's called a double-strand DNA break all on its own, that you might need a couple of those to do it, and that's how you kill the cells. Then there's the alpha particles, which is basically a helium nucleus. So if you remember your periodic table, which I've forgotten, and I do this every day, it's 2 neutrons and 2 protons. It doesn't go very far at all. It's like, you know, like this, it's like a piece of paper practically stops it, or it does stop it. But it has a whole lot of energy. So it can actually break that DNA strand in the tumor. It just cuts all the way across it. So it has one particle can kill a cell. So that's kind of what they are. That's a little difference there. But I'm still not going to talk about alpha, sorry. I'm going to start with, hey, well, what are we doing with the beta world? So right now, there's something you may have heard of, lutetium DOTA-TOC. I talked about DOTA-TOC back before with the imaging. I kind of said I didn't think there was any difference between DOTA-TOC and DOTA-TATE. Somebody does. Why? Well, there's a guy in Germany who does a lot of stuff with neuroendocrine radioactive materials and so forth, and Dr. Baum, and he did a study a while back, and these tend to be hodgepodge studies, just so you know. The great thing about Europe is that it's really a lot easier, it seems, for them to get some kind of experimental treatment into a patient. You can sign a piece of paper as a patient, and they can give it to you. They don't have all this, I don't know, they don't have all this FDA, and we got to do all this stuff to get there. The problem with that is then you end up with a bunch of different kinds of patients getting the agent. So there's no consistency between how aggressive the tumor is, what is the tumor type, that kind of thing. So like in this trial, there's 50 patients, half of them are maybe GEP-NETs, and then half of them are like a thymus or a lung or whatever. And then it's almost like they're, I don't know, this sounds like squirrels, because they're like, okay, we did this one. Ooh, what's this agent over here? Let's try to link this to this, and then we're going to do this again. And then it's like the first one just kind of disappears. I don't know. So anyway, there is some data in this particular, admittedly, random mix of patients who got it, maybe a little bit longer progression-free survival. So anyway, there are now 2 trials, phase 3 trials, that are running with this compound, lutetium DOTA-TOC. I believe that the COMPETE one is in the, they've already closed randomization. That one, what did they do? Kind of the same target population as the NETTER-1. They're just kind of giving it in a little bit different way. I think it's 3 months apart instead of 2 months. The COMPOSE trial is looking at a similar population to the NETTER-2, actually, and we're giving it a little bit more quickly in 6 cycles. So, you know, what does all this mean? We'll talk a little bit about that later. Then there's something where I was mentioning earlier, oh, what about pairing 64 copper with 67 copper? Well, they're going to do that, or they are doing that, but they're doing it specifically in pediatric neuroblastoma with this company that has this agent, this Sartate. Why are they doing that? They're going for an orphan drug indication. So it's kind of a little bit easier maybe to get it approved that way. So I don't know. I don't know what's going to go on with this, but right now it's being offered to a very limited population, none of whom are in this room. What about that antagonist versus agonist? This is one that there's a lot of. Dr. Google says a lot about this. The most recent one is by, hey, that guy, Dr. Baum. Look what he did. Let me try this LM3 stuff. You know, interesting results there. I don't know if anything will come of this, to be honest. People have looked at another type of agonist, this JR11. They did a phase 1 trial. I can't find any results on that. What's TB? 161 terbium. Wow, that sounds pretty cool. I've never used that. I'd love to. It sounds fun. They're looking at proof of concept actually versus DOTA-TOC, you know, so against something that we don't have yet in the US. What's going to happen with that? I don't know, but it could be really cool. Just as like something to throw out here, several years ago, 5-6 years ago, I was involved in a trial with an antagonist, this lutetium OPS-201. we did we did a couple of patients, and it just kind of disappeared. The company just decided they didn't want to pursue it, and it just went away. So that is one thing that we do see in this field. We see things that maybe look really promising, but then it either takes forever to get out there because there's not enough money or nobody's interested enough to like invest in it, or I don't know, somebody just loses interest in it and they're like, oh, I'm gonna go on to that next cool thing. I mean, I really wanna use thorium. That sounds super cool. So I get it, this idea from a scientific standpoint, but I'd really like it if we could follow through on some of these things a little bit better. Anyway, that's just my soapbox. All right, here it is, alphas. So there's multiple alpha particles that we think are suitable for imaging. Obviously, we don't want to give you like uranium, right? I mean, so there's only some alpha particles. We don't want to do bomb-like materials. We're not, So we do have one alpha particle, the radium-223, that is approved in the United States. It's called Xofigo. It's used for bone metastases only in patients with prostate cancer. Could it be used for patients with bone metastases elsewhere? Yes, as long as they have a certain type of bone metastasis called a sclerotic or bone-building type metastasis. This doesn't work on patients who have the ones that are destructive. Anyway, the problem with radium, even though we've got it and we've even got it approved, you can't tie it to anything. So we can't make it link up with a receptor seeker agent so that we can get it into those somatostatin receptor positive cells in neuroendocrine tumor. So we got to throw that one out. Can't do it. Then there were some early papers, I found some, and they were talking about bismuth-213. Ooh, okay, what's that about? Problem with bismuth, half-life, 45 minutes. So how are you going to do that? You have to have a generator on site to actually treat people, and they have to be pretty close to it. So that one doesn't really seem to be going anywhere. Actinium-225. So this is the one that seems to be the most promising, only because recently some places have shown an interest in dedicating the resources to actually make it. If you make it with the generator model, you can only get a very small amount per year that is available worldwide, because the way it's produced is based on leftover stuff from bomb production. Yeah, so I was really excited about actinium in 2011. I was on a trial using it, and the results, it was for a totally different kind of thing. It was for leukemia. And it was looking pretty good. We did 4 patients, and then you couldn't get actinium anymore, and it just went away. But now I am told that because of the interest, and not just in neuroendocrine tumors, we do have to thank the folks who deal with prostate cancer, because it's such a huge population. They are driving this as well, because these types of therapy are available for those patients as well. We apparently have secured a good supply of the actinium, so I think that it will be here. It's got a almost 10-day half-life, and it seems, it seems like we're going to be able to get it, so that's positive. Guess what? They started off with DOTA-TOC. What happened to that? I don't know. You can find very little information about it. They did a study with it. It seemed somewhat promising, and then it just didn't happen. And DOTA-TATE got picked up. There was a study by an investigator, Bilal, in India, which showed some real promise for this. And now there's actually we're now in phase 3. It started off as 1. We've recently closed that and started randomizing for the phase 3 portion, the Action 1 study, where you combine it with DOTA-TATE. And it's patients who have the grade 1, grade 2, well-differentiated GEP-NET, so similar population to the NETTER-1, but these patients have already had Lutathera or some beta and progressed on that, and then we're going to try to see if the alpha, so a retreatment with an alpha is effective. So that's pretty exciting. You may also have heard about the lead compound, 212 lead, DOTA-TATE. Some of this just it's still looking for those same receptors. It's just sometimes you've got to tweak the receptor-seeking agent a little bit to make it link onto a radioactive material. So that's why it's different. It's only got a half-life of about 11 hours. So that causes some issues in terms of getting it. We like these longer-lived, like 5 to 10-day things, because if it has to be made in, I don't know, Italy, like when we started off with lutetium dotatate, it takes a little bit to get there, right? So 11 hours, I don't know. That's one thing that makes me a little bit nervous about this. But anyway, they did a phase 1 trial. It was small. The only results I could really find was that in the 10 patients who got kind of through the dose escalation phase, they had an 80% response rate. I don't know. So that was enough. So now they're going to do a phase 2 trial, which I believe is ongoing. They are looking at patients who have not had any PRRT. So a totally different kind of thing. Why might alpha first be better than beta first? Well, honestly, I don't know. This is one of these big questions we have. Would it be better to hit him with the alpha first? Would it be better to hit him with How about this? What if we did one alpha, and then we did one beta, and then we did another alpha and a beta, and then we did another beta and alpha? I don't know. But I'd love to be able to look at all these things because we want to come up with what is the absolute best thing that we can do in the world of nuclear medicine to help patients, right? So basically, what do I think kind of is really what's available now or in the near future? As far as retreatment or for alternative types of tumors beyond GEP-NET, I think we're already there. There's going to be more data coming, but I have not had, knock on wood again, I've not seen insurance denials for patients who want to get the standard of care Lutathera who have lung tumors or thymic tumors. I've even gotten some really weird ones, kind of esthesioneuroblastoma. Okay, we'll do it. We've done a few of those patients. So I kind of think we're already there. And as far as retreatment, we're kind of already there too. It'll help to have the data because, as I'm sure everybody knows, sometimes insurance companies can be really hard to deal with. And right now, Lutathera is approved for 4, and that's it. But like I said, we've had some luck. But it'll be great to have the data. NETTER-2, we've closed it out. Information is going to be coming out about that like really, really soon. I think you're going to see that upfront treatment is a definite possibility. Higher grade treatment, yes. And then we'll eventually get that retreatment data as well. COMPETE and COMPOSE are both pretty far along. They're phase 3 trials. Assuming that the data is good, I don't know why it wouldn't be, honestly, because it's very similar. I think we're going to get those. How is that going to help us? Well, I guess it's an alternate agent. It might be easier to get retreatment if insurance is an issue. Maybe it will show a better efficacy. I don't know because we don't have the results. They're also doing some interesting things in those trials where they're directly comparing to other standard of care agents like the everolimus and so forth. So I think that'll be helpful. And then Action 1, this is the only one that is an alpha particle that is in a phase 3 situation, which is the phase right before, hopefully with positive trial results, it would then get approved. Where are we on that? As I said, randomization for phase 3 opened pretty recently, and it's supposed to last about 4 years. So could it go a little faster? Possibly. I hope so. So for right now, as far as getting an alpha into a standard of care situation, I would say it's going to be several. It's going to be several years, but maybe 3, maybe 4. And hopefully we'll have another tool in our nuclear medicine armamentarium that can help you out. And I believe that's it for me. So thank you very much for your attention.